Welcome, everybody. We're very excited to have you here tonight for our webinar on equine herpes myeloencephalopathy. We chose that topic because it's been quite an important year in terms of outbreaks. We had the large outbreak in Europe, starting in Spain and spreading across to other countries. We also had a large outbreak in Ontario around the same time, and also a smaller issue at the World the Equestrian Center in Florida. So with that, we felt it was important to review the disease as well as talk about reporting of the disease in Canada, because that's a very, very important topic. And that's why CAHSS exists, is to support not only communication through reporting, but also education as well. This webinar is also supported by CEVA, which is the Canadian Equine Veterinary Advocacy group. And they're kind of a new group that is also acting as liaison between equine veterinarians and government. So we're thrilled to have Dr. Nicola Pusterla here. Many of us on the call will have worked with him over the years, particularly with respect to EHV1 outbreaks. Dr. Pusterla graduated from the School of Veterinary Medicine at the University of Zurich in 1991. He worked in private and academic sector with a focus in large animal internal medicine. He earned his PhD degree through the University of Zurich with an emphasis on vector-borne diseases, and we can use you for that at some point too. In 1998, he joined UC Davis, where he currently holds an appointment as a professor in equine internal medicine and dentistry. His research focus is on selected aspects of equine infectious diseases with an emphasis on epidemiology, clinical disease understanding, diagnostics, prevention, and treatment. So please join me in welcoming Dr. Pusterla to our webinar, and thank you so much for agreeing to do this.
Let me see if this works. Okay, can anybody see the screen? Works well.
Yes.
Well,
Yes.
thanks, Dr. Moore, for the introduction, and thanks to CAHSS and Dr. Long and Dr. Burns for keeping me at work a little bit longer than usual, so that I can give this webinar. Just kidding. It's I'm always a little bit passionate about infectious diseases, especially when we deal with them, and when it comes to EHV1 and specifically as it applied to myeloencephalopathy, it's not any different. We'll hopefully all experience some small outbreaks, so well familiar with the disease. There are many aspects of this disease that are kind of evolving. If you think what the disease is, it's a very rare complication of a very common respiratory virus. If you think about it, we're just looking at the tip of the iceberg, and we're really all freaking out about it. By the way, we should. What I want to do is to talk about various aspects. With every single outbreak, we learn, we get a little piece of the puzzle together. Every outbreak is different because it's generally a very specific virus, it's a very specific population, and it's also a very specific way to handle it. And I hope I'll be able to circle this and give you a little bit of a perspective on some of this confusing information when it comes to, the biology, the genotype, talking a little bit about diagnostic, which is a passion of me specifically when it comes to herpesvirus 1. I think we can do better. And then talk about, how to handle an outbreak, what kind of medical intervention should we do, potentially not do. As Dr. Moore mentioned, this year hasn't been any different than any other years. I mean, if you look at the media and what is reported out there, we got outbreak of EHM worldwide this year. North America has been hit hard, and Europe has had to experience what we experienced in 2011 with the Octon outbreak. You're probably all familiar with the Equine Disease Communication Center website. This, to me, it's always the place to go when I try to figure out what is active in a specific area. And I do apologize in advance if the information is not 100% complete, but I looked at what was reported for Canada throughout this year, and what I found is a total of 9 outbreaks. I broke them down to individual cases, and to me, an outbreak is more than one horse, so let's call it 2 or more than 2 horses. And these report were throughout the year and involved 3 provinces, Alberta, Ontario, and Quebec. And then I went on CAHSS website 10 minutes ago, I'm not joking on that, and then saw that there were 2 distinct active cases in the Quebec City region. So it seems that, you know, this is the time of the year we start seeing them. We got some change in the husbandry. It's getting a little bit colder. Horses are coming inside, and we have little changes in risk factors. And I'll definitely expand on that a little bit. Now, to show the impact of an outbreak and how every single outbreak is slightly different, I wanted to go through 2 very large outbreaks. That the first one, the Octon outbreak, hit the US and Canada as well in May of 2011, and then the recently reported Valencia outbreak. So if we go on the Octon outbreak, this was following a very large event in the Western horse industry. There were a total of 420 horses at that place. The outbreak involved horses that originated from Western states, total of 10 US states. I also believe that there were 1 or 2 cases that returned back to Canada. This was caused by a neuropathic genotype. If you're not familiar with neuropathic and non-neuropathic genotype, I will expand on that in the next few slides. But just to make the case here, it was caused by D752. It's considered the more neuropathic, the more virulent one. The interesting part of this outbreak, probably the largest and best documented outbreak in US history, is that USDA and APHIS specifically got involved early on in this outbreak, and they made it mandatory to report every single horse clinically affected, and they differentiated between EHV1 infection. This will be a horse that has fever as well as respiratory signs and laboratory support of EHV1 infection, as well as neurologically affected horses, EHM horse. So a total of 90 cases, 57 EHV1, 33 EHM. If you look at where the horses came from, 54 of these horses were horses that actually were at the Octon outbreak, and the remaining 1 were horses that were exposed at home, so secondary or tertiary exposure. Total of 13 horses who had to be euthanized. These were all neurologically affected horses. If you look at the stats here, morbidity, which is the number of horses with clinical EHV1 infection, there were 13%. The mortality were 3% amongst all horses that attended Octon, well understood. If you look at the fatality rate in EHM cases, which mean the number of EHM cases that were euthanized, humanely destroyed for medical reason, this was close to 40%. Now moving to the Valencia outbreak, you're probably all familiar with this outbreak. Happened in February of this year in Spain. Interesting outbreak. There were a total of, depending on who you talk about, 752 horses in that area. The outbreak was caused by a non-neuropathic genotype, also referred as N752. It's hard to find comprehensive information on this outbreak. What I was able to find is out of the FEI website, approximately 100 clinically affected cases. Most of them were horses with fever and respiratory signs. There were 15 reported EHM cases in Valencia, and a total number of 11 out of these 15 horses were euthanized. If you look at the stats again, the morbidity is similar amongst the 2 outbreaks with 13%. The mortality is, is relatively low. If you look, we're looking at, 1.5 to 3% amongst all attended horses. If you look at the fatality rate, this is where it gets a little bit dicier. For the Valencia outbreak, 11 out of these 15 horses with EHM that were in Valencia at that showground had to be euthanized. So fatality rate of 73%. So quite dramatic outcome for a horse that develops EHM. This is one of the reasons why there is a lot of emphasis from a regulatory standpoint at documenting and controlling where these cases are, but also finding ways to mitigate the outcome during an outbreak. Now, to give you a little bit of a background, one aspect of EHM that has always fascinated me is the disease expression, and not any different than what we experience these days with the ongoing pandemic. Why is it that in certain instances where you have the right virus, the right population, and the right circumstances or environment, you head towards these outbreaks? And that's a multifactorial process that is difficult to sometimes predict, and it's sometimes difficult to control. A few years ago, around the mid-2000s, various research groups were actually looking at virulence factor, thinking that it is the virus that determines the outcome. And what they did very elegantly, they sequenced two EHV1 prototype strain. One was the AB4, the typical representative of an EHV1 strain that was associated with neurological disease. And then they also sequenced the entire genome of what they called non-neuropathic EHV1, the V592. And I must say, this terminology is very confusing, and to some extent, and we can debate about that, not necessarily up to date. But look at it as a strain that causes neurological disease and a strain that causes abortion. So they sequence everything, and they found that the overall divergence, and these would be substitutions as well as insertion, was very low, less than 1%. Of interest were single nucleotide divergence that would lead to amino acid changes. Why that is important is because a single nucleotide can change the amino acid, and that change in amino acid can actually alter the function of that specific protein. And then one specific nucleotide, single nucleotide polymorphism that was of interest is the one that was found on the DNA polymerase gene. That gene is also referred as open reading frame 30. This is an important gene. It is a virulence gene that is responsible for appropriate or enhanced replication of the virus. So position 2254 of the nucleotide sequence, there is a guanine when it comes to the AB4, to the neuropathic, and that translates in the amino acid aspartic acid, symbolized by the letter D. So you'll see this synonymous G2254 or D752. That defines a neuropathic strain, a strain that has or is associated with neurological disease, a strain that has the possibility to induce neurological disease. The opposing genotype is the N752, added in a position 2254. That would relate to a non-neuropathogenic. Now, the dogma has been so that all EHV1 strain either are of the D752 or of the N752 genotype. That has been the dogma. They are either red or they are blue. Well, the reality is that there is actually a third genotype, and this was reported in 2020 out of an outbreak in France, and we reported this year on an outbreak out of Pennsylvania, a new genotype where position 2254 of that open reading frame 30, there is actually a citizen, and that translates into histidine at position 752. So I'm just making things a little bit more complicating by adding a little bit more terminology. And I hope this graph here, this picture here, will make a little bit more sense. So if you look at the historical two genotype, we have the A2254 on your left. This would be considered a non-neuropathogenic genotype. On the right, we have the G2254 characterized by aspartic acid at position 752 of the amino acid sequence. This would characterize a neuropathogenic. If we look at the bulk of the disease of these two genotypes, And before I go there, one aspect is that the N752 is the genotype that is the most commonly spread amongst horses. This is considered the less virulent of the two. It has a selection in surviving the host by not killing the host. So the bulk of the disease for these two genotypes is what is here represented in the center. This will be rhinopneumonitis. This is where 99.9% of EHV1, independent of genotype, will be caused. The N752 is or has a predisposition to induce abortion, is shown here with this aborted fetus on the left. It is associated with a greater frequency, but it's not exclusive. We still find approximately 20% of abortion, EHV1 induced abortion, that are caused by a D752. If we look on the right, as would considered or represent a horse with EHM, the majority of these cases are associated with a D752, but not exclusively. There's two publications, two studies out there that found that 15 to 24% of outbreaks are actually caused by an N752. And remember the two outbreaks that I mentioned early on. The Ogden outbreak was a D752. So that would be the prime example of what this more virulent strain can cause. The Valencia outbreak that was actually associated with a greater fatality rate was caused by a N752, the one that is considered less virulent. Now, to add a little bit more confusing with the new genotype H752, this genotype was found in two outbreaks. These outbreaks were characterized by fever, distal limb edema, respiratory sign, as well as neurological disease. So the 2 points that I want to make here is the first one is, since most of the diagnostic laboratory, I can only speak for the US, based the EHV1 detection on allelic discrimination, meaning the test that allows to differentiate or detect either an N752 or a D752. If this type of diagnostic is used today, 2021, then an H752 would be missed. You would be missing an outbreak caused by this new variant. The second aspect, which, it's my personal opinion, and if I'm wrong, I think I'm gonna debate that I was even on this call, but it is the fact that we put too much emphasis on the genotype. And that is mainly because if you look at the EHM outbreak, they can cause by birth. And the overall impression is that, well, if it's a D752, we need to be very careful. On the other side, if it's an N752, we're probably gonna be okay. The reality is, I look at EHV1 as one virus that may have different colors, may have different genotype, but I like to look at it as one virus. And each of these genotypes has the potential to be associated with any of the clinical condition. And I'm going to show you a little data from a little study that we completed just a few years ago, looking at the genotype of horses with EHM, laboratory confirmed EHM cases that were either managed through our teaching hospital or managed through our state lab. These were horses with neurological signs compatible with EHM, as well as laboratory support of an infection through the qPCR detection of EH31 in nasal secretion. What we wanted to look is, first of all, distribution of the two genotypes, but we wanted also to look at potential prevalence factor, differences in prevalence factor in these two populations, so horse infected with an N or a D752. And if you look at the result, first of all, we have a similar distribution of cases. There were 30 out of these 65 cases, or EHM cases, that were caused by an N752 and 35 by D752. So we're almost 50% for each of these genotypes. There wasn't any difference in age, nor was there a difference in sex. One of the differences that we found was in breed. We had fewer warm blood, more quarter horses than standard bred in EHM cases that were caused by a D752. So it's kind of interesting to look at a breed predisposition for genotype. We need to be careful here. There is, however, work that was done by Lutz Gehring a few years ago that showed that there is definitely a breed predisposition probably goes back to the breed-specific inflammatory responses or anti-inflammatory responses. So what he found is that EHM is more prevalent in very specific breed, the Spanish breed, the ponies, the draft horses, the standard bred, just to name a few. If we look at this data and go back to the Ogden outbreak, Ogden had predominantly quarter horses and was caused by D752. If you look at the Valencia outbreak, it predominantly warm blood, and that was caused by an N752. When we look at clinical signs, there was no difference at the exception of urinary incontinence, which is considered a more severe presentation of an EHM case. Urinary incontinence was associated with greater frequency in horses infected with a D752. And if you look at the survival rate of these two genotypes, it was very similar. 36% of horses infected with an N752 had to be euthanized versus 52% with a D752. So I'm not saying that these two genotypes are similar. I'm just saying in the population of horses that we see or are referred to our hospital and throughout California, we have equal distribution with somewhat similar clinical signs. Now, one of the limitations of this study is we were unable to really quantitate some of the clinical parameters such as ataxia or maximal rectal temperature. If we're looking at predisposing factors, it's really important to understand predisposing factors. If you understand what potentially can trigger an EHM outbreak, we potentially can interact with it. So if you look at what are predisposing factors, well, first of all, you need to have EHV1 circulating. When we're talking about EHV1 circulating amongst horses, we always think about clinically affected animal. And the reality is there's a lot of subclinical infections. A lot of horses out there that experience EHV1 infection without showing clinical signs or without having severe clinical signs that are perceived. You may have a horse that appears a little bit sluggish, maybe has mild elevated rectal temperature. If nobody takes the rectal temperature, nobody will really know that the horse is infected with EHV1. We know that elevated rectal temperature is a predisposing factor for horse to develop EHM during an EHM outbreak. What I'm trying to say here, during an EHM outbreak, so what defines an EHM outbreak? You got to have the first horse that develops peracute or acute onset of neurological deficit and has a laboratory support of EHV1 infection. Any additional horse out of that same group that has an elevated rectal temperature develops an elevation in rectal temperature is a reflection of viremia, has 40 times greater chance of developing EHM as an animal that doesn't develop elevated rectal temperature. We know that age plays a role. EHM is not a disease of young stock. It's a disease of young, middle-aged to older horses. If you looked at the Ogden outbreak, these were young horses, 5 to 7 years of age. If you looked at the Valencia outbreak, these are middle-aged, young to middle-aged horses. If we look at older horses, there appears to be more susceptible. That's actually the model that is used to reproduce the disease. It's using the old horse. There is also a sex bias. We know that females are more commonly presented or represented in EHM cases. The question is always, well, why is that? It is surely not completely investigated. One theory is the immunosuppressive effect of some of the steroidal progestin, the estrus inhibitors that are known. Progesterone is known to be, immunosuppressive. So that's maybe one possibility. We know that seasonality plays a role. This is a disease that we see generally during the colder month of the year, which has a lot to do with the husbandry. You bring a larger number of horses in the same environment, poor ventilation, you increase the risk. And in some nice study that Dr. Josie Traub-Dorgetz did out of the Ogden outbreak, she found greater number of biosecurity risk. And these are tying the horse outside the stall, using the wash rack, allowing the horse to drink from a communal water source, having healthcare provider attend the care of the horses. With that, I'm saying having a farrier or a veterinarian examine a horse for reason other than fever or neurological signs. looking at, fomites, hands, equipment as a source of transmission. The number of classes competed, as you can imagine, the risk of transmission increases the more frequently these horses get in the show ring and there is commingling of horses. And here's an interesting risk factors out of the same study, vaccination. And I'll be talking about vaccination towards the end. That's a very sticky point where I feel like everybody has an opinion. So we'll probably spend the next 10 hours talking and debating over vaccination. But in that Ogden outbreak, and remember, this is a statistical observation based on a relatively small number of cases involved in this retrospective study. So they found that horses that were vaccinated within 35 days of the event were at greater risk of developing EHM. Kind of blows my mind thinking that, well, it should be the opposite. As I said, that's one observation. We need to be careful not to ignore it. We need to be careful not to overinterpret it. But here's a theory that is, in that circuit of high performance horses, the tendency is to over vaccinate horses. So what happened if we over vaccinate horses with vaccine that mostly induce an antibody rather than a cell-mediated immunity? We bias the immune system and kind of prevent the immune system to really remove these infected lymphocytes during the lymphocyte-associated viremia, potentially predisposing these horses to then having neuroinvasion, allowing the virus to actually interact with endothelial cells of the central nervous system. For those who have never experienced a horse with EHM, that's pretty dramatic. Most of these horses generally have a preceding event a week before. They'll have elevated rectal temperature. If it is measured, well understood, they may have mild respiratory signs. They can even have abortion. We've seen horses with acute onset of neurological signs that were monitored very closely and never had an elevated rectal temperature. Remember, you're dealing with biology. We're not dealing with black or white. We're dealing with gray all along. There'll be always cases that really defeat and challenge the textbook. Generally, these horses, you can see from the picture on the standard bred, are horses that present with hind limb, first of all, weakness, paresis, ataxia, proprioceptive deficit. They have a hard time getting up. They may be dog sitting. They may develop low sensation in the perianal inner area, urinary incontinence, decreased skin tone. We'll also occasionally see horses that have a more central involvement. They'll be very stuporous. They'll have signs of encephalopathy. These are generally horses that have a very poor outcome. We also see horses with vestibular signs and occasionally horses with brainstem involvement. So we're looking at cranial nerve deficit. I'm gonna run this video. This is a little video, and I hope this video will work here. And I do apologize if it's a little too low. Standard bred mare, middle age, put in a sling for a reason that you're gonna see why. This is this horse was in isolation. You can see this horse is very weak, incoordinated in the hind legs, is shifting around. I may have seen it. This horse also has a urinary catheter. But the interesting part, the front legs are working actually very well. And this is a horse that, overall is remaining bright, alert, and responsive and has interest in food. That is, I would say, the most common presentation of an EHM case. Now, where do we go from a diagnostic standpoint? Well, everybody has a little bit different opinion. Remember, we're dealing with a suspected diagnosis because the final diagnosis will be based on necropsy, histology, and immunohistochemical detection of the organism, generally based on the clinical signs and the history, where you have multiple horses with fever, respiratory sign, and sudden one horse develop acute onset of neurological sign. That should be that little red flag that pops up. You have to think EHM. If you run your minimal database, your CBC, your SIA, you may have indication of an acute inflammatory process, likely viral in origin. If your CBC shows mild anemia and lymphopenia. If you look at SAA, if you're a big proponent of using serum amyloid A, these are cases that will be very high, in the hundreds up to the 1,000. If you collect cerebrospinal fluids, you got to get that collection as close as possible to the disease process. Generally, a lumbosacral tap is going to be better than a C1, C2, or an AO tap. Now, one of the characteristics because of the vasculopathy is that albuminocytological dissociation. Well, the CSF has normal nucleated cell count, however, has very high to very high protein concentration, as well as that orange discoloration due to the vasculopathy. Now, while this is great, not every single horse presents with this condition. And I hope that Dr. Leclerc is on this call. She's just dealing with a case. Maybe she can expand on that, where a week after onset, that CSF tap was absolutely normal. So in some retrospective study, approximately 15 to 20% of horses presenting to the acute onset will have normal CSF. Why CSF is essential is because most of the outbreak happened on Friday afternoon, where you have no access to the lab until Monday morning. An easy and elegant way to document it, you're dealing with a vasculitis, a vasculopathy, and there's not many viral diseases that cause vasculitis, is actually to perform a CSF tap. And the CSF tap has elevated protein concentration and is xanthochronic, has that orange tinge to it, then you know you're dealing with a vasculopathy. You put the two together and you're likely dealing with an EHM case. You can also do serology. Serology is still an efficient way to document recent infection, either in a non-vaccinated animal with a very high titer during the convalescent period, or using an acute convalescent serum sample and looking at a fourfold increase in titer. However, that will not help you during the acute onset. If you really want to have support of an EHV1 infection, you have to document and detect the organism in blood and nasal secretion. I'm going to repeat that. The essence of a diagnosis, suspected diagnosis, is to detect the organism, make an attempt to detect the organism in blood and in nasal secretion. These are two different compartments that will give you two different pieces of information. Blood will tell you if the horse is viremic or not. Nasal secretion will determine how much virus is shed. So a direct association with contagiousness of that horse. Now, if you have a horse with these clinical signs, multiple cases, positive in blood and or nasal secretion, you can put the two together. Even better if it has elevated protein concentration and xanthochronic CSF. You have as close as possible to a diagnosis you can ever get. Now, I realize that most of the laboratory that offer EHV1 testing report the results in a qualitative fashion, positive and negative, which is a little bit unfortunate because EHV1 has a lot of potential. It is a lot plays into the numbers game. And if you look at different disease presentation, and this graph here represents the EHV1 load in blood and nasal secretion for 3 groups of horses. And the results are expressed here as number of target gene per million cells. That's just an arbitrary chosen way to express them. You could use that as number of target gene per swab. If you look at horses with EHM, 60% of these horses will still be positive in blood. Not 100%, 60%. Why that is because they're towards the tail end of an infection, towards the tail end of the viremia. However, all these horses are positive in nasal secretion, with some of the highest amount of virus present in nasal secretion. And that's an aspect that I really don't understand. You think that that horse is at the end of an infection. The amount of virus in nasal secretion should be low. It is not. And that explains why these horses are true typhoid Marys. They paint the environment with the EHV1. If we look at horses with respiratory signs and fever, these are the EHV1 horses. They are positive in blood. That's a reflection of the viremia and the fever, and they're positive in nasal secretion with loads that are somewhere in the moderate level. And then the third group are the subclinically infected horses. 15 to 20% of horses among an outbreak will be infected without developing clinical signs. If you measure these horses and you detect HV1 in blood and nasal secretion, the minority, a very small percentage of these horses is positive in blood. Kind of makes sense, because if they were positive, they would have at least elevated rectal temperature. However, they are all positive in nasal secretion, and the amount of virus shed in these horses is highly variable. It can be very low, but it can also be very high. And this is one of the greatest challenge that we have. We generally have a tendency to ignore the healthy looking horses during an outbreak and focus more on the sick horses. Now, what you do during an outbreak and how you deal? Well, the first thing to do is book a ticket and airfare and go on vacation, because you're going to be stuck with answering a lot of phone calls for the next 2 weeks. Just kidding on taking a vacation. But, you know, for most of us, that's the way it feels. It's truly exhausting. The key element of any outbreak is communication, communication, communication. Without that, you can't reach a successful positive outcome. The key element is really in this outbreak is to focus on biosecurity. And I'm not a big proponent of a 40-page document. I don't have the time to read that. I generally focus on 3 or 4 elements that I can apply to the specific situation. But it is essential to stop the virus from spreading. And this can be easily done by implementing hygiene measure for all horses. And I really want to underline that it's all horses. It's not just the sick horses. It's not just the one in contact. It's all horses. The biggest challenge that I have in outbreak and control this outbreak is not to determine that the sick horse has EHV1. That's a given. If that horse has an elevated rectal temperature during an EHM outbreak, that's it. It has EHV1 infection. The greatest challenge for me is to determine that every single healthy horse out there isn't infected with EHV1. Therefore, I need to treat all these horses in the same fashion. I can't have 2 citizen type treatment. I can't just put a lot of biosecurity around horses with clinical signs and ignore the healthy looking horses. And that generally requires testing. I do realize that a lot of regulatory authorities don't like the testing of healthy horses. I'm a big proponent of testing. Let's see what's going to stick to the fan. Let's monitor and test all the horses, not the sick one, but all the healthy looking horses, and determine how far has the virus spread. That way you can actually take these horses that are shedding and move them. And that's another very important component. You got to physically remove horses from the barn that are shedding EHV1, independent if they are clinically affected or if they are subclinically infected, because these are typhoid mares. You don't know how much they're going to shed. And this is the way that infection is generally spread, not directly, but generally indirectly through hands and equipment. You have to monitor horses on a daily basis and do it in a fashion that you don't introduce actually EHV1 to these horses. There is new technology out there. Merck Animal Health is coming out with a thermal chip where every single horse has a chip that measures in real time the rectal temperature, and you can have a scanner and just go from the outside of the stall, and you can imagine how quick you can monitor 30 horses in a barn. It would probably take 3 minutes, and you can just scan the rectal temperature that way and know exactly who has a rectal temperature that is above what you consider normal for that specific horse. Otherwise, you have to take rectal temperature. Why rectal temperatures? Because that's considered an early indication of infection. That really applies to horses that are not receiving any NSAIDs. Most of these show horses are on NSAID anyways, so you really have to consider maybe reducing that cutoff of what you consider an elevated rectal temperature for this horse. You also have to do a lot of cleaning and disinfection. So disinfection in a dirty stall doesn't work. I'd rather clean the stall and not disinfect than just throw a disinfectant over a dirty environment. So you got to remove the biological matter. You got to clean and disinfect high traffic area to minimize the amount of virus that is present. This is a virus that is easily eliminated with the majority of the disinfectant. One area that has gained a lot of interest is medical intervention. And believe me, it has been abused and overused, as you can imagine. So the idea is that once you have documented an EHM outbreak is to prevent any additional case. The way we do that is we monitor these horses very closely. The idea is to only use medical intervention, any of these drugs, if an animal displays clinical signs, elevated rectal temperature, or has evidence of viremia. And there's various strategies. Probably the most efficient strategy is the use of antiherpetic drug. You really prevent the virus from going from the nasal secretion, using an Uber to the central nervous system. That's what you do. It works best during the early stages of the disease. Valacyclovir doesn't change the outcome, or any antiherpetic drug doesn't change the outcome of a horse that already is displaying neurological deficit. It, however, changes the amount of virus that is shed, but it does not change the outcome in these EHM affected horses. In early stages, probably the best drug that we can have. Nice work that was done by Dr. Lutz Göring, looking at an in vitro interaction between infected PBMC as well as endothelial cells of the central nervous system. We know that these interactions are halted and reduced, meaning there's less virus that reaches the endothelial cells of the central nervous system. You can also use aspirin. Aspirin will interact with platelet, will inhibit platelet activation, hence prevention of the thromboembolic event. That is also used with heparin, either low molecular weight or unfractionated heparin. And one of the easy remedy that came out of the study from Dr. Josie Trapp-Dorgetz was that horses that received supplement, which majority of these show horses receive supplement that contain zinc, were less likely to develop EHM. And it is known that zinc has an antiviral effect. It cross-links the double helix of DNA. So a relatively easy way to do. What I would urge any of you not to do is during an outbreak to put every single horse on any of these drugs. I've seen many outbreaks that were prolonged up to 8 weeks because all these healthy, uninfected horses were put on valacyclovir for 6, 7, or 8 weeks. And by the time the valacyclovir was discontinued, the virus was still circulating and these horses got sick. So first of all, you're gonna use drugs that are not following good stewardship. And the other risk is truly to induce resistance. We know that EHV1, you can induce resistance by maintaining drug levels or anti-herpetic drug levels. So selecting strain that suddenly become resistant. So again, medical intervention should have an indication. And the two indications that I see, I'm going to talk about that in the discussion, is early clinical disease. Elevated rectal temperature would be, the best indication. And the other one, if you're dealing with horse and you test this horse on a regular basis, a horse that has evidence of viremia would be a horse that I personally would try to interact that viremia, try to keep it in check. And now the long attended topic of vaccination. And I just love that because everybody has an opinion. But the way I look at it, I'm not going to tell you what to do. I'm going to just read you the facts and you can make up your own opinion. So if you look at the commercially available EHV1 vaccine that are labeled for the use in North America, they are labeled as an aid in the prevention of rhinopneumonitis. That's one of the first claim. And specific vaccine, not all of them, but specific vaccine is also claimed for the prevention of abortion. Not a single vaccine out there that I know of, unless experimental vaccine, has a claim for the prevention of EHM. So you could argue and say, well, let's not use it. I mean, if we can't prevent EHM, what's the point of using it? So look at what a vaccine can actually do in the field of respiratory disease. And this is based on experimental infection in recently vaccinated animal. We know that vaccinated animal will generally have a lower severity or less severe clinical sign. And that's mainly because the virus causes less pathology. So one benefit, reduction in the severity of clinical disease. There's also a significant reduction in the amount of virus that is shed. And that, in my opinion, is essential, considering that by having less virus that is shed, there's less virus that is present in the environment, meaning the risk of exposure, transmission has been reduced. And some vaccine has also been shown to have an impact on viremia. They'll lower the amount of virus present in peripheral lymphocyte. Now, well understood, that's all based on experiment, where you have naive young horses, you immunize, and then you challenge them at the right period. How does this look with our older horses? How does it look if the horse has been vaccinated 6 months ago? We really don't know. If you decide to vaccinate, I would urge you not to vaccinate animals that have experienced the disease or animals that have tested positive, that may be a subclinical. So we're looking at boost vaccinating this animal, trying to get a very fast anamnestic response, hopefully cell-mediated and humoral, in these healthy, uninfected animals, to hopefully get some of the benefit that routine vaccination will do. And if you look at the AP vaccination guidelines, it is at this stage, not recommended to vaccinate horses during an EHM outbreak. And if you look at the risk factors, there's studies that show that it is a risk factors, and studies that show that it is not considered a risk factor. So the long attended last slide, the take-home message. Well, we're dealing with a very uncommon presentation, a rare presentation of a virus that is highly prevalent in horse population. Now, the outcome is very devastating for horse owner, for the economy. If you look at the Valencia outbreak, they had to shut down any competition for over 6 weeks. So 4,000 FEI horses could not compete over a 6-week period. You can only envision what the financial impact is, on top of the burden of sick animal and potentially animal that had to be euthanized. I want to point towards the genotype. Genotype is great, but genotype is not the whole answer. The outcome and the development of EHM is a multifactorial process. The virus, and we know that the D752 is amongst all the genotype the more virulent one, but also keep in mind that the other genotype can cause similar disease. The other aspect is when you're looking at diagnostics, and a big proponent of a multi-gene approach when it comes to EHV1. First of all, you got to know if EHV1 is present or not. That's targeting a universal gene that detects all EHV1. Ideally, using quantitation. With quantitation comes a better interpretation of the risk of disease transmission, but also better characterize the viral stage of that specific horse. And then last but not least, the genotype. The genotype is important from an epidemiological standpoint. But to me, it's more important to know that the horse is or isn't infected with EHV1. When you're dealing with these outbreaks, if there's one aspect that you got to keep in mind is communication. Some of you have experience with outbreak and probably don't want to have any future experience, but you realize at the end, once everything normalizes, that communication is key, and you got to have people that are involved and give you support. Prevention of EHM is, looking at the medical intervention as we talked about. Be very judicious in the use of some of these strategies. There is generally no ill effect of using some of these drugs, but I think we need to be more intentional in which horses should be treated, which horse, we can just continue to monitor. And last but not least, as I mentioned, there is unfortunately up to now no vaccine with the claim to prevent EHM. I put here my information if you have any question on diagnostic, anything that I can help you. I've been involved with various outbreaks this year, in the past few years. in Canada, we always have the capability to, support some of the diagnostic testing. It's just to gain some epidemiological information. I'll return it back to Dr. Moore, who will start the roundtable topics.
Well, thanks so much, Nicola, for that wonderful talk. Well, we're going to circle back to you, so don't go anywhere. And for those who have questions for Dr. Pusterla, you can write them in the chat, or you can wait till we circle back and unmic yourself, and we'll unmute yourself. We'll remind you of that in a minute. So we're going to pursue the communication aspect really in one of the next discussions. So we're going to do a cross-country checkup, if you will, and talk to representatives in different provinces in Canada, and just to talk to them about EHV1 outbreaks in their province. And some haven't really had any, but what do they have in place for reporting and surveillance, and what do they have in place for communication? So I'm going to start with BC and Dr. Debbie Parsons, who is an internal medicine specialist out there. Where are you? There you are, Debbie. How about kicking us off and just discussing sort of some of the challenges and what takes place in BC regarding EHV1 and testing, et cetera.
So in BC, just like a lot of the provinces, EHM is a notifiable disease. So you're supposed to report to the chief veterinary officer within 24 hours of if you have a suspicious case. And there's a couple of ways that you can do that. If you go on to the website, there is a link for you to send an email, or else you can call as well. From there, we don't really have a place that the chief veterinary officer reports it to us. So sometimes it gets sent to the CVBC. Sometimes Dr. Burns finds out that it's going on, and then we try and put it onto the Canadian Animal Health Surveillance System or Equine Disease Communication Center, one of those two. Those are basically veterinarian driven for the vet to put their case up once it's been confirmed, a diagnosis. It's not really a big issue here in British Columbia, seeing as we have very few cases. We have not had an outbreak here in 15 years. At least. We basically have one a year. We had the most recent one was in August of this year. Prior to that was January 2020. And prior to that was April 2017. So whether we're just not testing a lot of these cases that are individuals, or we just don't seem to be having it here. Okay. What else do you want to know about?
What about testing?
Testing. So basically, the majority of our veterinarians either are going to use the Animal Health Center, which is the BC laboratory that's in Abbotsford, or IDEX. Now, True North Diagnostic Laboratory, located in Langley, BC, will also take the samples, but they forward it on to the Animal Health Center. Now, the Animal Health Center gives us a turnaround time. They don't really have a published turnaround time. It's about between 24 hours, and my last one was 7 days, so somewhere in there. If you send it through True North to get to the Animal Health Center, they say that it's a 10 to 14 day turnaround. The other option is to send it to IDEX, and IDEX usually, it says it's a 2 to 3 day turnaround time. But sometimes this has been prolonged to as long as 10 to 14 days in the last year or so, whether it be because of reagent issues or issues at the border if they send it to Sacramento instead of to Markham, which they used to do. And you can get that through IDEX, either through selecting for specifically for herpes, or through their neurologic panel that will include the herpes, the West Nile, and an EPM, a Western blot. There are some different instructions in terms of the swabs between the True North and IDEX. True North says they want a moistened swab with saline, and IDEX says they prefer a dry swab when you're taking your sample. So those are our options. Both of those are reported as a positive or negative, and they do give us the difference between neuropathogenic and non-neuropathogenic, but we don't get quantitative answers for that. So some of the hurdles that we've been seeing in BC are mostly developing a communication line that goes right from the case through our governing bodies and out to the general equine practitioners, so we know what's going on in our area. The other thing is, because of our very low prevalence here, it is kind of hard to convince the owners on biosecurity testing, and that this is truly a real problem for their horses. So sometimes if you do have a case which you suspect herpes, it can be a little bit of a battle to get people to do the quarantine, not move the horses and all of that stuff, because they haven't had the personal experience of knowing people that have gone through such outbreaks before. I guess that's about it. Is there anything else you want to know about BC? Pretty quiet out here.
Thanks, Dr. Parsons. We might circle back to you. We'll see. So let's continue on to Alberta. Dr. Ashley Whitehead with the University of Calgary School of Veterinary Medicine. So Dr. Whitehead, what do you have to tell us about EHV1 there?
Yeah, I mean, we were kind of one of the epicenters for the Ogden, Utah, so we got quite good at dealing with it at that point, although since then it's been fairly sporadic. I pulled the information from the EDCC that Nicola had presented earlier, and so we've had one case reported this year, but I know of at least a few others that have happened, including one 2 days ago that was identified on postmortem, but has not been, it's been reported provincially, but has not gone out on the other systems. And that really comes to one of the issues we have in Alberta is our provincial reporting is only for the neuropathic mutation strain. So if you have that non-neuropathic strain, it's not notifiable within the province, and it doesn't have any of the reporting that goes about at the provincial level. Now, they are all notifiable, which means that we're not dealing with any kind of intervention from the province, more of a notification. And the other problem with that is that the notification on the Alberta website, unless we have a large outbreak, is quarterly. So the last one was the end of August. And so it's not getting very quickly updated on there. And so we really have to rely on the practitioners in order to put it out there on EDCC and on the CAHSS information system so that we can get that information out. I would say biosecurity is definitely one of the biggest issues that we have, especially given that we have a very high Western population and there is a lot of young horses that come and are put at the rails, even though they're not competing. The other part of it is that what I have seen is that a lot of fields are directly beside each other and they are nose to nose touching of neighbors' horses. So even if there is a quarantine that the owner does, the neighbors' horses may have been exposed and don't necessarily follow that. And then also the large barns that we have a lot of outdoor housing, but with so many different owners and so many different veterinarians, and trying to maintain and create who's in charge and who's going to deal with that outbreak can be quite difficult. I mean, we see that a lot with strangles, but as well when we're dealing with potential herpes virus as well. Testing, similar issues that Debbie had mentioned there. We did have quite a few, and when I spoke with IDEX, that's where a lot of ours goes, also PDS. Sometimes the lack of reagents from the COVID testing has been one of the biggest cited issues. We did have a question related to that genotyping. Most of the laboratories do recognize either, and a lot of times they will call it wild type, which we're, as we talked about, we were trying to avoid that. But so the neuropathic mutation, so they'll call it the neuropathic strain or neuropathic positive or non-neuropathic, not saying that you're as we just heard, our case isn't neurologic associated with it. But there is some laboratories like PDS, which I believe you have to request to do that secondary testing of your PCR sample. So you can request it at the time, or if you get a positive, and then it costs a bit more to do that to determine what the type is on it, depending. But HL, IDEX, they all will report a positive as either a neuropathic or a non-neuropathic. Do you want me to show a couple of resources now, or do we want to come back to that at the end, Allison?
Let's circle back to that. We could show that at the end.
Sounds good.
Thanks, Ashley. Is Dr. McMillan on? I haven't seen her. Oh, there she is. So Dr. Kathleen McMillan is with the Atlantic Vet College out in Prince Edward Island. I'm skipping to you because I'm going to be a little long-winded, so I thought you should go before me. So tell us about the situation out east.
I have to admit the situation out east is pretty quiet, which, you know, as far as I'm concerned, is a good thing. The last reported case that I'm aware of was in 2004 in Nova Scotia in a young standardbred. I don't recall it ever being reported here in Prince Edward Island. And I guess the difference also in the Maritimes is that it is not a notifiable disease. So here in PEI, we're working on that, trying to make it a priority and make it a notifiable disease, but currently it is not. So that is a real problem as far as communicating when horses could potentially be infected, or if there's an outbreak. Certainly social media can speed that along, but as far as a kind of a group or organized network, we haven't really done that. So hopefully that's where CAHSS and the EDCC and SIVA can certainly help with that as well. I think we all have the same issues with biosecurity, mobility of horses moving around, not just within the Maritimes, but also from Ontario and out west. And testing, we do not actually perform the test in-house. So our tests are, our samples are sent to Guelph, to the Animal Health Lab, to be tested there. And I think, you know, as Deborah said, it's hard to convince some people sometimes to do the testing and spend the money, you know, to do that.
Exactly. And I think, you know, all three of you have really highlighted some major issues in terms of timely testing, which really, like, if you can't figure out what it is, it makes it much more difficult to try and control. And then communication's the other big piece. If you aren't able to get the word out in a somewhat official manner, then it is more difficult to let people know what's going on. Now, I left Ontario to the end because although we had a very challenging year with EHV1, we do have some successes from it, and life may be a little bit easier in some regards. So in 2021, we had 14 facilities under voluntary animal movement restrictions for EHV1. So just backtracking a little bit, EHV1 is immediately notifiable under the Animal Health Act in Ontario. So the laboratories are required to notify OMAFRA, the Ontario Ministry of Agriculture, Food and Rural Affairs, of a positive test for EHV1. So of those 14, we had 9 facilities with equine herpes myeloencephalopathy, 2 facilities with abortion outbreaks, 1 facility with a respiratory outbreak, which normally we wouldn't address, but this was a very hot case. So we had a lot of febrile, a lot of sick horses at this particular facility. And then we had another facility with both abortions and equine herpes myeloencephalopathy. Of all those outbreaks, there were 11 horses euthanized associated with EHM in particular. Now, this just ties in with what Dr. Pusterla said. So we had 4 facilities with a neuropathic strain, so the D752. we had 6 facilities that had EHM cases with the non-neuropathic strain, or the N752. So we had more facilities affected with the non-neuropathic strain. So just on that note, AHL does quantify, they give you a cycle threshold for EHV1. So if you're doing multiple testing, which we have done in the past at racetrack outbreaks, you can actually see horses that were shedding higher numbers, so lower cycle threshold numbers, getting better as time progressed, and also those that kept continuing to shed. The one thing that AHL is doing now, because of the H genotype that was identified in Pennsylvania, AHL is now doing the universal genotype initially to see if EHV1 is present, and then they will genotype it if it is. So that is a little bit different. So in terms of the successes, I think the most noticeable thing this year was people actually talking about it on their facility. So in previous years, it was always the hush hush. People don't want to say because they don't want to feel like they're being attacked by others in the equine community. But this year was very different, and kudos to the first farm that was affected, because they went right on social media and said, we have it, and this is what we're doing to protect the horses on our facility and then make sure it doesn't get off our facility. And then that just started a whole chain of events. So with every other facility that became affected, many of them went on social media to say, hey, we have it too. So I thought that was kind of a breakthrough. So there isn't the trying to hide it anymore. It's like, let's talk about it and let's deal with it. So the other thing that was great, we had early reporting by veterinarians in some situations. So they're not required to tell us unless there's a major outbreak with many, many deaths, but many of them do. They call us and they say, hey, I think we might have an EHM case and we're waiting on testing. And it gives us the ability to talk to them about biosecurity then and there, so they can be prepared and kind of talk through, if it is positive, what they might do. The other thing that was also a success was really the leadership shown by these practicing veterinarians dealing with these outbreaks. And it was fascinating to me because you had some vets were more like the drill sergeant. This is what we're doing. I don't care what you guys want to do. We're doing this. And then the others that were a little bit more, I'll help you, facility manager, however you want to deal with it. This is the science and I'll help you along. And it was all very effective. All the veterinarians were tremendous, and they stepped up and led those outbreak challenges. I thought they did a great job. The challenges for us here, our testing is very quick because we have AHL and Guelph for the most part. We can get them back the same day if they're local, or we can get tests within 48 hours, 72 at the outside. So that's good. Our challenges where we had many facilities with several veterinarians, and that can also be challenging, like who's going to be in charge. So it's usually who has the best relationship with the facility manager or has the most clients at that farm. And that actually worked out pretty well. Horse owners not understanding how transmission works. So they were phoning, they wanted some of the tax stores to be putting the foot baths outside, their stores phoning us at the government, how come you're not making them do this? And so it was a bit of talking about how transmission occurs and what horses are at risk. Testing, I know Dr. Pusterla talked about testing. I think for the facilities we've had to manage so far, the testing has to come with a plan. So initially the vet's like, oh, I want to test. And then I'm like, okay, what are you going to do with them? Do you have somewhere to put positive horses? Can you split up groups, which we don't generally like to do. We like to keep social groups together. And that leads to the next issue, which is there is a lack of isolation areas in many of these farms. They just don't have the space. They jam the stalls are full if they have them. And they might have the paddocks full for outdoor boards. So that is a real challenge. And then when you're in the wintertime, who are you going to keep outside? And we only had one farm that had sort of a breach in biosecurity, if you will. They had a case that came up, and it was in a herd. The index case started in a herd that was out 24/7. And they were doing a great job monitoring fevers, but there was 2 horses they couldn't get a temperature on because they weren't very nice. And one of those developed EHM. So if they'd been able to detect the temperature, it may have worked. Now on the microchips, we do have horses, standardbreds in particular, that have had to be microchipped as part of their identification. The temperatures, the temperature recording don't work very well on those chips. So if you're going to use them, you have to sort of look for the trend and not use the exact number, if you will. So you could potentially use them, but I think most people are a little off of those microchip temperature readings. But anyway, that's my situation from Ontario. I'm going to just toss it back to Ashley for a moment so she can show you the resources, because reporting is really an important part of this. And Ashley's going to share her screen.
Maybe. Did it come up here?
Yep.
It's here.
All right, so we have a couple of websites here. And so we've talked a little bit about EDCC. And so on EDCC, under the disease information, there is an equine herpes specific page that's not just specifically neurologic, but all of the herpes. It has the latest outbreaks, and then has a fact sheet for owners on the information, the resources, an EHM fact sheet, as well as this is the guide for state health, animal health officers, which is a good overall guide, and including initial outbreaks, so what to do in that first area. So Dr. Nat White, I believe he was on the call with us. He works with the EDCC and spearheads that along with the Infectious Disease Committee for the AAP. And so we have been working really hard over the last years to make sure that Canada is represented. And right here, our first one here is on Canada, and that we now have a map even on here in terms of when you look at the disease alerts. So if you have a case or of any infectious disease, as a veterinarian, you can report that. So this is limited to veterinarians. It is not just limited to provincial authorities. This is any veterinarian with a disease positive laboratory confirmed case. You can come on here and fill out the alert request form, which has some basic information about the alert. All of the cases that are submitted through here are vetted by a veterinarian. So usually that is Dr. White. When he is on vacation, then there is a group of us who assist him, and they follow up to make sure that these have are actual cases and have been diagnosed with laboratory confirmation, so that we can ensure. They also go at the kind of county level, so you're not going, you can do in an area which is not going to identify. We do really want to keep that confidentiality, and that's the same for CAHSS as well. The national or federally reportable diseases, they do have a little bit of a different reporting structure, but we try and maintain that. And if we look at the equine disease dashboard that we have on CAHSS for EIA, which is the main one that we're going to see on there for our federally reportable ones, you'll notice that it's a larger area. So we're not going to say, oh, this is this specific barn. The other thing that I wanted to show as well, because it's a little bit harder to find, is on the AAP, if you go to this guidelines here, and then you scroll down onto the side, there's infectious disease control. There is guidelines for the infectious diseases, which are the specific ones. There is also an equine herpes resource area. Our goal is to have all of these information updated within 3 years. And anytime there's something new that comes up, then we update it with that committee immediately. So if there's a new information. So what we were talking about before in terms of vaccinations, we updated the equine herpes guidelines for the vaccinations as soon as we have that information on there. And all of our fact sheets and guidelines have the date now on them so that you know when they were last updated as well. And we try to have the information for both the owners as you saw on the EDCC, as well as for the veterinarians. And there's even easy links here to sign up, because that EDCC will send out the alerts directly to your email, similar to what we have with CAHSS. And a couple other resources on here. Were you going to show, Teresa, the dashboard, or would you like me to show that as well?
If you have it handy, please go ahead.
So on our CAHSS website, and I am in the middle of nowhere, so it's a little bit slower, I apologize, in our Equine. This dashboard is actually incredible. I'm quite impressed with it, and we are currently working, there's our previous ones, on Potomac horse fever. So would you like to have another time to watch that? But we are working to get non-notifiable and federally reportable diseases on this as well. And that's going to be kind of, we're currently working on our definitions to make sure that they are consistent. So you can see here, at the moment, this is all of the diseases, but you can, these are the ones that are on federal aspects of it. So we'll go to equine infectious anemia, just because we all know that this year has been bad for us. You can see that this year we have had significantly more cases, mostly in Alberta this year of EIA. And so this dashboard, as you can see, is quite user-friendly, and it's a really good way to show, it will show that county level information on them. So those are the ones that I wanted to just highlight here to make sure that everyone knows them. And Teresa, did you want to go through the process with CAHSS in terms of how they get sent out and the information comes in?
Sure. So yeah, we actually have it two places. So there's the dashboard, and then we have a disease alerts, which is really just a quick summary. And that's sent out by email, and then it links back to the dashboard. So if you want to be on that list where you sort of get an email when there's a new equine disease alert, you can become a member of CAHSS, and on your profile, select equine, and then you'll be added to that email list. And when there's an alert, it will be sent out. And we're working with our CAHSS Equine Network. One of my goals for the next meeting is to talk about what disease alerts we want, because we don't want to overwhelm people with disease alerts, but we want them to have the information they need at their fingertips. So it's going to continue to sort of grow. And we've been really fortunate that we've been able to connect with EDCC and share the information with them and from them quite well. So I'm really pleased about that.
And I think as all of the different provinces had highlighted, we have different disease definitions going across all of the different infectious diseases, including herpes. And so it really does come down to us as clinicians putting that information into the systems that get out to the individuals. And hopefully we see more situations like Allison was describing, where people are coming out and discussing it themselves, versus when we had Ogden going on Facebook, there was death threats against individuals who people thought had cases. And so it's kind of, I see the progression changing. People are more interested in knowing, and especially COVID has pushed us, I think, in a good direction of that, following what's going on and knowing that that information is valuable. But there's always going to be those trolls that are out there, but I think it's a very positive direction that we're going in with disease reporting.
I agree. And on that note, we have Dr. Stephanie Chapdelaine from MAPAC, who has offered to give us an update on the cases in Quebec. Welcome, Stephanie.
Everyone. Yeah, so as Dr. Pusterla said at the beginning, that actually we have 2 cases that are active nowadays in Quebec. What I wanted to share with you is, actually it's the second outbreak that I have since I'm here at the MAPAC, and I've noticed different things about things how they go, and also issues that we have here in Quebec. And well, actually, at first I wanted to say that here in Quebec, the herpes virus is actually the neurologic form is the one that is designated, which means that the labs they need to notify us the cases, and also veterinarians should report the diagnosis through our form on the website, the MAPAC website. So they have to put on that the report, and also they could also write to me when the vets know my email address, they could write to me. So actually what I find, or the issues that I've noticed through the different outbreaks that I've I don't know how to say that I've done or that I've followed, is that actually the quarantines are very difficult to follow. Usually what we see is the biosecurity is the fact that it's not always understood properly from the horse owners, and also from the barn owners. And also, as some people said it at the beginning, is that media, social media is also something that is that all the news go very quickly, and sometimes a lot of deformation of the information is noticed also. And other things that I've noticed is that like I have many people that write to me, and the horse owners don't always understand the disease. So sometimes I think all the communication that we try to give them, they don't always receive it or understand it properly. So I think sometimes the difficulty is all that communication with their veterinarians. And I know when the veterinarians try to how do you say that? I don't know how to express it, but when the veterinarians are trying to control the outbreak, sorry, it's not always easy for them to give all the information, and that everyone knows and understands the information. So I think that's sometimes a problem. And which I noticed also is that veterinarians, sometimes there's more than 1, 2, or 3 veterinarians that work in the facility. Let's say the outbreak that we have right now, there's more than 1 veterinarian, and sometimes it's not always easy for them to control all the owners that are there. So I think there's a lot of work to do. And also I think working as a team, as Dr. Pusterla said in his presentation, is very important, because I could notice that it's very important to work as a team, because we cannot arrive to a good I don't know how to express it, but we need to work as a team. Yeah, that's right. So so that's I find the issues here that we have in Quebec is mostly that.
Yeah. Communication, teamwork. Yeah, that's
Exactly.
universal. Yeah. Well, thanks so much for that, Stephanie. That was great.